So somewhere in 2007, this issue went to a very high level concern for the policymakers of the state, primarily because the policymakers themselves were from this field. And we had at least 75 to 80% of the population, either borrowing or selling their assets to get access to quality health care. So that was a situation which was existing somewhere in 2007. And our state had a dubious distinction of so many farmer suicides at that time. So a lot of commissions went into study why exactly this is happening. The second most important reason cited at that time by one of the commission was Ms. Jayadikosh Commission, was that of the high, escalating healthcare cost in the rural areas, especially when it comes to catastrophic diseases. So we at the same time have demand, but from the supply side, more infrastructure, more expertise was available in the private sector. Though infrastructure was there in government sector, but expertise was highly lacking. Government has been trying several ways to bring in expertise to government hospitals and government, health establishment, but with little success. So why don't we tap the expertise and infrastructure available, which at that time 30 to 40% was, lying vacant or unused. Now here came the challenge, and we were given the task of forming a scheme with non-traditional methods. When you speak about health insurance or a health system, there is a traditional way of thinking that you pay premium, identify premium for an insurance company, pay them and forget it. Later it is their role. But we deliberately decided that it should not be like that. This is the first reform that we made in this scheme. We didn't want it to be a traditional insurance scheme, and government had to take equal responsibility because we are dealing with masses. So that's why this model that you are seeing in the screen was adopted. Here a trust, an independent trust was formed. In fact, this was formed primarily to cut down bureaucracy from the government side. In the sense, this is an independent trust, though it is, under the government, but we can take day-to-day, minute-to-minute decisions. So this trust was formed with the Chief Minister as the chairman and other trustees, and then the insurance companies, whoever is there, identified through open bidding mechanism. But here one thing has to be very clear, that the product was designed by the government and the trust. We published the product to the insurance companies to quote. We never asked them to, model our program. So we wanted it to be as inclusive as possible. We are going to touch around 80 million people of this state. There's around 20 million families, and roughly 85% of the population of this state. This was the task given. Network hospitals, in terms of service providers, certain definite quality parameters were put, again untraditional, and these quality parameters were brought into a transparent platform, so that all the inadequacies are avoided, and we would like to show it to the patients that this is what is existing in this hospital, and choose from what you want. The choice is given to the patients. Now a hospital which treats patients, which receives patients, poor patients properly, they will get more and more patients. So that was our idea. It clicked, in fact. And then of course another area of inclusion. Normally health insurance work on the principle of exclusion. We wanted to put in elements of inclusion. Another major feature of inclusion that we have put in was the health workers, or called as Arogya Mitras, exclusively meant for the scheme. Now these people were selected by the self-help groups of the state. AP has a very big tradition of self-help groups. 99% of them are controlled by women. 8 lakh self-help groups we have. Now these people selected these health workers, and they were put in the primary health centers, basically to handhold the people. The same Arogya Mitras were available in the network hospitals too. So we didn't want, everything is a bureaucracy. Either you go to a PSC, you go to a private hospital, you go to a government hospital, everywhere there is a bureaucracy. So we want to cut this bureaucracy and, facilitate the patient so that he is taken care with the, fullest possible extent. Of course, all these things are not possible when we are dealing with around 16,000 patients in a day. We cannot do it. We cannot balance the load without the use of technology. And that too real time. Real-time technology of tracking people, patients, one by one, individually, personally, with treatment protocols, treatment parameters, referral protocols, etc. So that was how the software company was started in. The entire domain knowledge of the workflow was developed by the trust in-house. We didn't go for any consultancy or anything. And it has been done on an agile methodology. It's not that we started all of a sudden and, everything was brought on a single day. Initially, we started with 2 fax machines. I still remember. We keep it as memorably in our office. And today, we are sitting with, and only 2 people were there in the trust, around 3.5 years back. And now we are 5,000 strong, working with a, very high-level backbone. Main features, 2 lakh coverage at 350 rupees premium per family. The total cost is borne by the government. The government has committed 1,200 crore for this project every year. And in the last 3.5 years, where we have been expanding slowly, we have, so far the claims is standing. This is of yesterday evening statistics. It is around 2,028 crores at an average cost of 29,000 rupees per patient. Now, through this scheme, we have also demonstrated one more aspect, that health insurance is not a costly affair, provided it is managed properly. Provided evidences are brought in, provided all negative aspects are taken care. The packages were designed, all these packages were put into an online system. Now, this is just only the documentation required for a patient is this card. Now, this card was also an innovative thing because every village, digital photo lamination centers were put. It was a 1.5 year project run by the public distribution system of this provincial state. And this state has given this kind of cards to 2.38 crore. That is around 23 million families of this state. We use the same database. We didn't duplicate. Now this database had got the digital photographs and the iris biometrics, etc. Now, in order to make them aware of the scheme, we made a health card. And this card costed us only 2 rupees per card. Now, because the database was available and it was given to every household in this state. It was a major politico-administrative process. So before the start of the policy, we made everyone know that they are covered under this policy. That is one mistake which normally we do in mass health insurance scheme. Even if the policy stops, people in the remotest village may not be knowing that they are covered in this scheme. So that we wanted to avoid. These are the Mitras. So we started as a pilot project with 163 procedures and 6 systems. Now we are running 938 procedures in all major, 31 human systems. All cases covered. We are also giving follow-up treatment for 125 procedures. Now this is another service, an innovation. Normally, no insurance scheme cover follow-up. Many treatments require follow-up treatment. And when it comes to poor people from villages, they neglect this aspect, even after surgeries, even after treatment. So we didn't want to take a risk there. So government extended, follow-up facilities for these patients. And today, I'll just go live and show you. Yeah. This is the current statistics, that is as we are sitting here. We have done around 19,641 health camps. Another innovation in order to go out and make it more inclusive, in which around 34 lakh people have been screened so far. And 24 lakh people have been registered in the hospitals. 11 lakh people have been treated as outpatients and around 8 lakh people as inpatients. In the last 24 hours itself, you can see the statistics on the left side. Around 21 health camps, 3,692 patients screened in those health camps, 4,000 cases registered, outpatients 10,254. I was telling you we are dealing with around 16,000 patients in a day. And I have got the medical records, the medical data of all these 16,000 patients online.